Welcome to This Week in Health IT. Today we have a solution showcase for you, and I'm really excited to bring it to you. This is the intersection of behavioral health and primary care, and it's a great solution that CommonSpirit is rolling out. My name is Bill Russell, former healthcare CIO coach, consultant, and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. I want to thank Sirius Healthcare for supporting the mission of our show to develop the next generation of health leaders. Their weekly support of the show this year has enabled us to expand and develop our services to the community. So special thanks again to Sirius Healthcare. Now, well, actually, one last thing. The competition on the referral program is going really well. If you're not familiar with it, you can sign up for Clip Notes, and then you can refer your friends to Clip Notes. And what's happening is people are referring it to their friends. They just go out onto the website, they hit subscribe, and they put your email address in there. And a bunch of you are amassing referrals, which is great. If you get one referral, you're entered into a drawing to get potentially a work from home kit from This Week in Health IT. If you get up to 10 referrals, you get this black moleskin notebook with the embossed logo on it. And for one of you, you're going to get the opportunity. I'm not going to force you, but you're going to get the opportunity to come on the Tuesday Newsday show with me, and we'll talk about the news, the health IT news that is impacting the community. Looking forward to that. Thanks for your participation. Really appreciate it. We want to get this in as many people's hands as possible. So now, great show. Looking forward to sharing with you. Over the last couple of months, starting with COVID series, we've done a couple of episodes on behavioral health, and I'm excited about this one because I think it just makes so much sense. First of all, it's a great health system in CommonSpirit Health, and it's also a great solution that Concert Health in partnership are bringing together. We have Spencer Hutchins. Spencer, what's your title? Are you CEO?
Co-founder and CEO. Yep.
Co-founder and CEO. And we have Christine Brocato, the Vice President of Strategic Innovation at CommonSpirit, joining. Welcome to the show. Welcome, Christine.
Thank you. Thanks for having us. It's exciting to talk to you about this program today.
Yeah, I'm really looking forward to it. There's so many exciting aspects of this, but I'm gonna let you guys tell the story. Sometimes I will talk over. I'll share the whole story and then say, okay, tell us more. But tell us about the partnership. Tell us what you guys are doing and why it's unique and why it's exciting. I don't know who wants to. Christine, why don't you start, and then Spencer, you can fill in some of the details.
Sure, absolutely. Well, so first of all, this program, the genesis of it began last year. So pre-COVID, we were in our markets, as we usually are, talking to our primary care physicians about some of the challenges that they see, what innovations that we need to bring to market. And a trend started to emerge with them saying that they're seeing more and more patients in their panel with mental health issues, and it was really concerning to them. But they also expressed a lot of frustration with lack of access to quality behavioral health services in their markets. And usually what happens is that there's 3 to 4 behavioral health therapists in the market that the PCP knows, likes, feels confident referring. And when those folks are at capacity, they're at a loss for where to send their patients, and end up spending more time with those patients in a visit, managing them more closely, calling, following up. And so they're doing this work today, not getting paid for a lot of it, and just frustrated with the lack of ability to send their patients somewhere confidently. And so we realized that there was a need to find a solution that would work for them. And they made one request of us, as they were like, listen, I'm dealing with a very diverse patient population, so don't get fancy. Don't give me anything that's super complicated that the majority of our patients really can't use. And so our team started to do research, and that's when we started to research different models and came across the collaborative care approach. in the thought that it solved two things. One is just the access problem. How do we get patients access to quality care more quickly? And then the second is a recognition of integrating behavioral health care with medical care. And that's exactly what collaborative care does. I would say that for a very long time, healthcare really separated the two. But what the research shows is that when you integrate behavioral health care into medical care, not only do you get better outcomes in terms of decreasing depression and anxiety, but you also have better outcomes in clinical care as well. So for all that reasons, this partnership made sense.
Yeah, absolutely. And I remember at the health conference a year ago, Bernard Tyson saying one of the things that we've done in healthcare, we separated the head from the rest of the body, and we just care for the rest of the body. And he was really passionate about it. He was talking about mental health. So Spencer, talk about this. This is really integrating primary care and behavioral health services. So give us an idea of what Concert Health does and what you guys brought to the partnership.
Yeah. So Concert Health is aiming to build America's largest and best behavioral health medical group. So we're now over 100 team members, the vast majority of whom are counselors and psychiatrists that work from home. And what we do is team up with medical groups and health systems that have a passion for integrating, but don't want to figure it all out themselves, right? Or looking for a partner. Dedicated group of our team, often bilingual, to support each of those primary care practices, and really are there to provide same day and next day access. So Christine mentioned we use a model called collaborative care management, which might not be familiar to a lot of your listeners, although I think the logic behind it will be for those engineers or technologists. I think in many ways it's a more engineering mindset to the problem. So the beginning is to start with recognizing that probably 50 to 60% of people with depression and anxiety don't tell you they have it, either because they don't realize it or they're embarrassed about it, or they're just hesitant to bring it up. But we've known for years that there's a series of pretty easy screening tools, really just quick surveys that you can give people at least on an annual basis or around any major health event, like a new diagnosis or hospitalization. And it picks up a lot more, not to diagnose people, but to screen them for higher risk, right? So it should be flagged for their primary care physician. So one thing we're doing is working with CommonSpirit to do that. How do you implement and scale that? So really everybody's being asked, and you pick up that 50, 60% of the people that maybe never were going to be missed by care. And then you provide a warm handoff. So now when a patient shows up in Bakersfield clinics they're able to say, let's say I'm the patient, instead of saying, hey, Spencer, you have depression, here's an antidepressant, you should think about seeing a therapist. You could say, hey, Spencer, looks like you're struggling with your nerves, with your sleep, with your mood. I see that a lot of people, and what I'd love is for a member of my team, Danny, to call you today or tomorrow. And what Danny does with a lot of my patients is checks in between our visits. And what she does is gives you the same tool we gave you this morning, so we can really quantify how you're doing. Just check in on how things are going, if this medication I'm giving you is working. And she's got some coping techniques that she teaches a lot of my patients they find helpful. So some people will recognize that as, oh, Danny is a therapist that's in-house. Others will just say, no, she's part of my team. You don't need to have that same division of this is something different. It's just part of a comprehensive primary care experience. But Danny would be one of our licensed mental health providers, and she'd just do that. Patient would experience us as a phone call or video visit, whichever they like, and often touching base 2 to 5 times over the course of that each month. And what we do is every month we give them that same assessment tool. In depression, it's one commonly used as a PHQ-9, or there's different ones for anxiety, suicide risk, bipolar. In each of those cases, whenever possible, really measuring whether or not I'm getting better as a patient, and then doing brief psychotherapy interventions. Each of our Dannies, each of our care managers then have a weekly check-in with one of our psychiatrists, using that data registry to talk through those patients that aren't getting better. So let's say, again, using myself as an example, let's say I am doing great with my morning meditation, but I stopped taking my antidepressant because I have erectile dysfunction. 8 weeks later, my PHQ-9 has dropped from 18 to 12. That's great. That's an improvement, lower, better on that score, but that's still pretty symptomatic. That'd be a classic person that say, hey, I'm feeling better, so I'm going to not bring it up, or I'm embarrassed about the side effect I have, so I'm never going to talk to my doctor about it again. By having that collaborative care team around, by having Danny with me, she'll know that. Bring it up to the psychiatrist. Doesn't need an hour-long visit. In that case, they'd say, let's drop a quick note to the primary care physician, remind her that congratulate Spencer on the meditation he's doing. Think about changing him to a different SSRI that's less likely to create that side effect, because it looks like we're going to need both the therapy intervention and a medication to make Spencer asymptomatic. So my primary care physician looks like a hero. She knows what's happening in my life, and she has an actionable recommendation that she can act on. And Danny's really making sure that I don't slip through the cracks, and that patient's being managed, and in my case, I'm being managed until we really declare success, which is when I'm asymptomatic, right? When I'm over it, when my depression's in remission and I can move on. So that's what we've been doing. We've been doing it for 4 years now, across 40 medical groups and health systems, and incredibly excited to be kicking off in Bakersfield with CommonSpirit, and obviously taking the relationship, hopefully, to many other locations around the state and around the country.
So I'm gonna come back to some really pragmatic questions, but I want to start in Bakersfield. And Christine, give us an idea of what you're looking for out of the pilot, and what you're learning and what you hope to learn.
Yeah, absolutely. We were fortunate to receive a grant from the state of California to implement integrated behavioral health care in Bakersfield and in Inland Empire. So that's where we're starting first. And for folks who aren't familiar with Central Valley, California, it's a very diverse population. It's isolated in the middle between Southern California and the Bay Area. And there's a little of what we call a little of everything. We have folks a lot of agricultural workers. We have a huge rural population, and when we think about the diversity in that population, it's pretty enormous. And so what we're looking to do is to implement this program with our primary care providers, and really demonstrate that we could prove out the results in this real world setting that we've seen in the research. And so we'd expect to see three major pieces, which is one, a reduction in mild to moderate depression and anxiety 90 days out. Two, a reduction in clinical, or an improvement in clinical outcomes. And so that would mean for chronic care patients, improvements in A1C, a reduction in ED and inpatient visits, and all of that contributing to a reduction in cost of care. And we also want to demonstrate that these results could be meaningful to the Medicaid population, which has always been, a challenge in terms of meeting their behavioral health needs. And so I think we have a pretty aggressive goal ahead of us, but we're really excited by not only the collaboration from our PCPs, but also in working with the payers in that market as well. I think all of us recognize that we need more tools to serve populations with their behavioral health needs. And so the ability to really track the data and learn together, I think is going to be great.
So I'm going to come back to you and talk about the physicians and how they're responding to it, how they're looking at it. I'm also going to go in the direction of the financials. Our listeners are primarily healthcare providers and whatnot, and right now they're sitting back going, okay, this is an interesting pilot, and you're not kidding when you say Bakersfield's diverse.
Right.
It is rural, it is industrial, it is people commuting into LA making $500,000 a year. It's everything and everything in between. So it really is a microcosm of a lot of different populations. But some people might be asking about the financials. What are the codes? How does this get funded? How does it get paid for? Which one of you wants to take that and talk about that?
I'll take a. Oh yeah, go ahead. I'll take a little overview crack, and then I'll pass it on to Spencer. Given all the robust research about collaborative care, about 2 years ago, Medicare released collaborative care codes, and these are CPT codes. And then many payers, major payers, followed suit. And so that was I think a wonderful win for healthcare, because it's a recognition that this type of model in integrating care with primary care, that it produces results. And I think some Medicaid payers reimburse it, some do not. Currently in the state of California, it's not. So the challenge is working with our Medicaid payers in the state and looking to be creative and prove out the results to establish those codes in the near future. Spencer, what would you add?
Yeah, I think that's a great overview. Medicare was the leader in 2017 on a pilot, creating essentially 3 new codes for those that really want to geek out. It's 99492, 99493, and 99494. It's a monthly case rate that covers this. But to do it, you have to prove you've assembled this 3-person team: primary care, behavioral care manager, and psych consultant. You're using a registry to track outcomes, and you're doing treat to target, meaning you're testing and learning based on whether or not you're generating results and changing the approach in psychotherapy and the approach in medication. And really, frankly, faster than we expected, the commercial health plans followed. Essentially, every major national plan and almost all the regional blues have covered this, added this to their fee schedule. The evidence is so robust, and everybody recognizes they need better access and better quality on the behavioral health side. And Medicaid has covered it now in 18 states across all sorts of different markets: Arizona, Washington, New York, Massachusetts, lots of places, red and blue, left and right, coastal and inland. California, in some ways, has been a little bit of a laggard, frankly. They're talking a lot about this. They haven't added it to the fee schedule. One thing that's inspired us from the beginning of the conversations with CommonSpirit and Christine is they said, listen, we're not going to solve this in an easy place. We're going to go to a place where the need is the greatest, and we're going to solve it for the communities that matter most about us. And I remember when they said, we really want to bring this to the Inland Empire, I said, well, it's not Medicaid, and California is not paying for it yet. So that's going to be complicated. There's a lot of managed care out there. So on the commercial and Medicare side, it's a little bit more complex. And they just put their foot down and said, this is the right thing for the market. And we're going to use our resources, our brand, our people to bring everyone to the table. And as you imagine, it's a little bit easier to go along with Christine, we're going to go talk to the plans and other stuff and say, listen, this is the right thing to do. Let's figure it out. And a little bit, if we can figure it out clinically and if we can figure it out financially there's nowhere in California we won't be able to do this, and there's nowhere in other CommonSpirit markets. That's been inspiring, and it's been exciting to do that, because we know to be useful at the point of care for that primary care provider, it needs to work for everybody. Those physicians, they're doing so much. They're seeing 35 people a day. They know 3, 4, 5 of them every day are going to have depression, anxiety. If we can find a way to support all of them, it's a life changer for them clinically and operationally. Oh, I have this person, they're my partner. Anytime I identify these problems, I know someone's going to be reaching out to the patient, checking in, documenting so that I can see the record, giving me useful recommendations. If you take a plan-centric view and you say, well, for my Cigna patients, I got this, for my Aetna ACO patients, I can do that. That doesn't work, right? It doesn't work in the day of the life of the doctor. And I think that's something we've been passionate about. We're so excited for Christine's leadership and on the ground to say, we're going to make this work at point of care, which means we have to make it work cross-panel for them, all payer. And that's what it unlocks the behavior change that drives the clinical outcomes that we all want to see.
Spencer, I'm going to go to Christine here, but I'm going to come back to you on a question around the technology and how I integrate it into the rest of the tools that I have for sort of an integrated digital experience. Christine, let's talk about the physician and the physician experience. Is Concert Health sort of white boxed in the background? Does it appear as like just part of the CommonSpirit team? How do the physicians? How do you get the physicians on board, or are they just naturally on board because it's the right thing to do?
Yeah. Well, so I'm an innovation person, and so I'm usually doing the big sell on a variety of innovations, and I have to tell you that is not the case with this. This is a situation where PCPs acutely feel the results of the lack of access to behavioral health in the market. And so when we were presenting this to the PCPs, they got it immediately. They appreciated just how much evidence was baked into the model. They put their hand up and said, "When are you coming to my clinic?" And I think it's for all the reasons that Spencer talked about. This is a model where they are staying at the center of the care, that they can follow their patient's progress. The therapist is documenting directly into the EMR, and then the physician is able to do any med rec that they can. And so for them, this is helping them with their schedule. This is a way to easily do a warm handoff to the therapist and feel confident that they know where their patient's going. And so for all those reasons, I think this is a program where we feel that there's PCPs putting their hand up and saying, "Okay, what about me? Let me get into the queue." Yeah. And I think that really speaks to the need that we feel not only in Bakersfield, but I'd say in a majority of our markets.
Yeah, that makes sense. Spencer, this week in health IT, so we got to talk about the technology aspects of it. I realize phone is some of it, and Christine stole some of your thunder. So you're documenting directly into the EHR. That's pretty exciting. Yeah. You have a digital tool. Can I integrate it into the other tools that I have? Give us an idea of some of the lay of the land on the technology side.
Yeah, our view has always been that we need to be more than an app, right? We need to build this organization as the medical group itself, because the magic is the people, the protocol, empowered by the right technology. And when we canvassed independent practices in large health systems, it wasn't that we were saying, "Hey, the only problem we have in behavioral health integration is I need a new SaaS platform that I can license." It said, no, we need to figure out how to find these people, how to train them, how to get paid for this service, how to do the work, right? And so we said, okay, we need to be that full service solution, not just that. Now, that said, we're proud of the technology we've been able to build, and we're really focused on is anything that makes the life easier for the patient, and most importantly, and second most importantly, the primary care physician and our team, our care managers and our psychiatric consultants. And so as Christine started at the beginning, we always said we want to treat all patients no matter their technological literacy. So from the beginning, we said this is a model that can be done incredibly effectively over the phone, and that'll always be an option, right? And so that is, but if a patient has a preference to do or wants to do video visits, they can do that. It's a secure link texted or sent to them. Boom, creates a video connection with their therapist. They can do that every visit or just the first couple to get to know them, right? And that can be really powerful too. The face-to-face can be great. Sometimes actually the phone can be a great way to access someone from a technology limitation, or we're calling them on their lunch break or on their commute home, or maybe they're so agoraphobic or so depressed that they don't want it. They don't feel like they can be up for a video session and get dressed but they will take a call and start talking to us. And that can be a great entree. From the primary care physician perspective, our view was there needs to be a single source of truth, right? The first time that we make a recommendation based on a med list or problem list that's 7 months old is the last time they read one of our recommendations. And so that is, we really need to work with the medical groups and health systems, say we need to have the ability to access the medical record and document directly there. Now what we're doing more and more as we scale is also doing back-end integration, right? Which says, okay, let's make sure we're not rekeying medical record numbers, patient names, other things, PHQ-9s, being able to pass them back and forth increasingly digitally. But I think really always having that direct interface connectivity to the EMR will be important too, because a lot of people use that phrase, "Oh, I'm integrated with an EHR." You say, well, what does that mean? It says, well, there's a PDF somewhere buried in some place the physician doesn't even know where to look. So yes, it could survive an audit. Yes, the information is there, but it's not part of their day-to-day operations, right? And our view is our team needs to be an extension of theirs, and they need need to see our messages come through just like we were a nurse or another physician on their team, so that they can really interact with us and those sorts of things. And so, we've really built our technology infrastructure around that, around how to enable that, how to make sure we can bill for it as well in these new time-based codes, and then be as light touch from the primary care perspective as possible, and just make it look like it's auto magically populating, even if at times that means our team's doing double data entry or something like that.
Yep, absolutely. It's I'm really glad to do this show. I love doing this show because we know there's such a huge need. This is such an elegant solution and a great partnership. I continue to be impressed with the things that CommonSpirit's rolling out, and really exciting to hopefully hear more about this in the coming year. I'd like to hear how the pilot goes, and I'm looking forward to reading the press release as you expand this into other markets. Now, I know I'm putting my expectations out there, but that's my hope.
We're excited about it too. And one of the things that we're almost like piloting within a pilot, and I think it's worth mentioning to folks who are thinking about behavioral health, is that we're using this as a way to learn about how social needs are surfaced when you're having behavioral health conversations. So when you are talking to your therapist, you may disclose that you have anxiety because you cannot pay for your utility bill, that you are food insecure. And what do we do when we hear about those things? And so we're working out workflows to be able to surface those social needs and get them to our care coordinators who can make those referrals into the community. And so starting to really connect a variety of programs we have so that we're overall just treating the patient holistically. They're going to surface medical care issues, behavioral health issues, social needs issues. How do we start to really connect those pipes so that those aren't separate issues? It's manifesting all together in the patient, and we're looking to address those needs. So I'm really excited about that aspect as well.
Yeah, that's the foundation of Catholic healthcare right there. Mind, body, and soul. It's the whole person. And hey, I want to thank you guys for taking the time to come on the show. And again, it's just, I appreciate the things you guys are doing. I'm looking forward to hearing from you next year on how this progresses.
Thanks so much. Thanks for having us on.
That's all for this week. Don't forget, sign up for Clip Notes, participate in the referral program. Special thanks to our channel sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, Sirius Healthcare, ProTalent Advisors, Health Next, and McAfee for choosing to invest in developing the next generation of health leaders. This show is a production of This Week in Health IT. For more great content, check out the website, thisweekhealth.com, or our YouTube channel. Please check back every Tuesday, Wednesday, and Friday for more great content. Thanks for listening. That's all for now.